We will start the ATI proctor test about 2:15. And then we'll try to get the group projects graded tomorrow. Dahlia and I are both going to be on campus.
What's that?
She grades
This
her
is from
groups,
a
I grade
simple
my
nursing
groups,
I
and then
printed
we
off.
get
My
together
printer
and
is
we make
running
sure
late,
we're
but
consistent with how we're grading.
it's just a
So
way to memorize.
it might be a bit yet till they get posted, but we'll try our best to get them in.
You can have this one if you want.
soon.
Yeah, I'm gonna try to make it where you can read it.
And there's a rubric
Yeah, 'cause I
that's
can
attached
print
to
more.
them, so
So
you
you go to
should be
like
able
the
to see the
website?
scoring on your.
It's a subscription that I paid
You
for.
should be able to see the scoring on your
It's like
group project. Based off the rubric.
$250, but
A year?
no, you just pay it one time, and it's good until you pass like the NCLEX.
Okay, we're going to talk about
I don't know if
kidney
that helps or
transplant.
not.
Kidney transplant for end-stage renal disease. The kidneys have failed. That's the person's now a candidate for that. My computer was acting funky, but I want to show this and continue. These are just fun facts. You won't need to know this, but you have about 70% function after you have one kidney removed. And if you're born without a kidney, your one kidney works overtime and performs about the same as if you were born with two kidneys. So,
But
I know.
But only 7% if you,
After you have one removed. Correct.
because it was used to do.
Pardon me?
Because your body was used to.
Yes, I guess. I don't even know why, but interesting fact now. For kidney transplant, they can be live donors, they can be deceased donors. There are contraindications, as you can imagine. I'm not going to hold you to those. Obviously, if there are some issues with hypertension and uncontrolled diabetes, those are the risk factors to begin with. They probably won't select that person as an appropriate candidate for that. This is important to know. I should have put this bold stuff in red. You're taking care of your patient following his transplant surgery when you notify the surgeon. If you have low blood pressure, why are you worried about that? Correct. And then why are you worried about excessive diuresis? Isn't that a good thing? Why would you call a surgeon about that? You don't want to dehydrate that new kidney, right? So yes, we want diuresis, but we don't want a lot more coming out than what's going in. So we want that new kidney to get good blood flow. We want that kidney to stay hydrated, right? So if you're given that criteria, look at your I&O totals that you're given to decide if that's excessive diuresis or not. So I could give you an intake of a certain amount, give you an output of a certain amount, and you can say, okay, that seems like a lot more out than in. You guys good with that? Those two criteria. Just keep in mind, I got to have this kidney hydrated. I got to have this new kidney with enough blood flow. And also just sort of a fun fact, the donor has more pain, guess it's not that fun fact, has more pain than the recipient. If it's from a living donor, the patient's kidney should start functioning immediately. If it's from a deceased, it takes a couple weeks. There are types of rejection, as I think we've already covered, or you probably already covered. Hyperacute, the new kidney didn't take to begin with. I know, super cheap, right? Acute could be a couple weeks post-op. Chronic could be over a period of time. Lots of complications, as goes with other types of organs and things that we try to transplant. The blood vessels can't get the flow going correctly. It could be stenotic. It can be lots of things. Indications of impaired perfusion. There are actually kidney transplant programs in different countries. And you'd say, I don't think I would probably ever do that. What if I offered you, if you donate your kidney, I'll give you enough money that you can pay for your kids' meals for the next year? Gonna do it? Not doing it. How much money? Enough to cover your kids' meals. Are you doing it or not doing it? All right. And are you donating your kidney? Your brother needs a new one. You giving it to him or not?
Maybe.
Depends if I like it.
Depends what.
Depends if I like him or not. Wow. I mean, that's what you guys do. Your brother takes really good care of himself. He's got 6 kids. He doesn't smoke. He doesn't drink. Are you giving him your kidney or aren't you? You're still not. Yes, some of you all did. Your brother's a heavy smoker. He drinks a lot, but he promises he'll quit all of that when he gets your kidney. You're giving it to him, aren't you? He's got 6 kids that are all little, and he's a single dad.
I'll take care of it.
You take care of him in rehab? Are you giving him your kidney? No? Is anybody giving your brother his kidney? He's got to quit all his bad habits the day he gets your kidney. Yep. How about your stepmom? Ooh, kind of mixed reactions on that whole deal. How about your child? How about someone that's got a 50-50 chance of taking with your new kidney that you're going to donate, and you have 6 kids at home? Yeah. You're going to donate anyways? I know you have 6 kids that need you. What? No. But they seem like a good person and do a lot of volunteer work. They're a volunteer firefighter.
Depends on what my history is.
Pardon me? Okay. What was that?
I said depends on like my family history.
On your family history, you've been cleared. You've applied, and they said you're good to go.
If my kids are gonna end up being something, I would rather do.
All right. So we have a student that's going to hold off in case somebody else needs it besides like one of her kids. So she's hanging on to her 2 kidneys. We got one that's donating theirs.
What do I get out of it?
Wow, that's where you just went. That good feeling that you donated your kidneys, what you get out of it. So lots of ethical stuff that we go through when we go through this. Exactly what you all just did. It's like, well, if it's this one, and what if you have 2 siblings that need kidneys? Because they inherited polycystic kidney disease.
Which one is more critical?
Which one's more critical, about the same? They're twins.
Well, I guess it's gonna go through.
Which one
Are they on?
Which one's your favorite? Neither? Okay, neither twin is getting a die.
They'll fight over it. How would cause that?
You mean money-wise? They're both doing well, but you're the perfect match for both of
If
them.
they're your siblings, then they have polycystic, and it's inherited disease, then our
You didn't get that gene though.
But still, what happens?
An adult.
So you're still holding on to your kidneys.
Or your kids,
How
yeah.
successful are they? They both are successful. They both need kidneys.
How many kids do you still have?
2 and 2.
We'll draw numbers. Let's draw numbers.
Wow, draw a number. We're not playing lottery at your house. So as you can tell, sometimes you as a nurse get caught up in some of those conversations, right? And sometimes you have personal feelings about those, first of all. And second of all, you've got sometimes mixed reactions with your family members and people making those. Right away I said, how about a stepmom? And most of you went like, oh, probably not. But if you get along great with your stepmom, and your mom's deceased, and your stepmom took good care of you all when you were little. So there's so many things that play into it, and especially when there's siblings and people that are having conversations about who's appropriate, who's not. Your job as a nurse is to give them good education that's accurate, and try to support them, realize the risk factors that play into that. You know, it is sort of, even if you're yourself personally, we had a gentleman in town that he needed one, same kind of scenarios I gave you. He's a volunteer firefighter, young guy, nothing he did lifestyle-wise that impacted his kidneys. He just got a bad set of cards and a couple of kids, and they put out this notice and said anybody that could possibly consider donating to him. I didn't really know him very well. I know his parents, but didn't know him. I'm like, yeah, I guess I'm going to apply. Like, please don't pick me. Please don't pick me. So, and then I had a history of 1 kidney stone like 20 years ago. That was on the questionnaire, and I got an email back and said, you're out. So there's lots of things that kind of get that narrowed down. And fun ethical discussions, but sometimes you as the nurse are in the rooms when there's a lot of that goes on, and you have to kind of help figure out how to be supportive of them. Renal trauma, that's the hematoma that I was talking about earlier. Make sure that someone is aware of that. That's bleeding underneath the skin that's going on. Make sure that gets communicated, make sure you're monitoring how big that thing is getting. Like I said, I always take a Panadol around the perimeter, so I know how much is changing over a period of time. Lots and lots of things that could be impacted by that. And treatment just depends on how much blood loss there is and lots of other situations. So probably the biggest thing from this section, which is a short section, was the whole piece about your patients you're taking care of him following his transplant surgery, when you need to call the surgeon. What criteria, what assessment findings do you need to call the surgeon about? And that was the whole low blood pressure and the output way more than the intake. Okay, now we're going to cover the urinary disorders. Oh my God, I just love this cartoon for some reason. Thank you for laughing. Yeah, there you go. We had our family Thanksgiving on Saturday, like my son and I, we go back and forth with us to do little fun things. And then my other son, who doesn't appreciate them as much, he goes, "Really, you two?" I said, "I would be in my class." He goes, "I wouldn't." I'm like, "Yeah, okay." Most common pathogens we talked about during Jeopardy is E. coli, just by proximity to the urinary tract. Always questioning why the patient's getting a catheter. Does the patient continue to need a catheter put in or not? UTI. You should not find very many of any of this in the urine, right? The higher the number, the more indications of infection in that urinary tract. Lots of things we can prescribe for those UTIs. Increased fluids, Stay away from things that are going to irritate your bladder. We'll go through more dietary considerations in a bit. Sometimes people say they take cranberry juice and cranberry tablets when they have a UTI. Studies right now show that doesn't really do any good once you already have a UTI. However, research has shown that if you take that daily, if you're prone, sometimes that can help ward off UTIs. So the jury's still out on that. Urethritis, inflammation of the urethra. Most common cause in males is sexually transmitted infections. Acute pyelonephritis is a kidney infection. Acute, as it says, it's a bacterial infection. Most common agent is E. coli, as we just discussed. Symptoms, typical of infection, fever, chills. We were talking about evaluating, palpating for costovertebral tenderness in clinicals on Monday. So I added this slide, if you can't remember what that was. I think you guys said it was on some ATI, there you go. That's how to target your palpations to determine if they are possibly having kidney issues. Placing the palm of your hand over that angle. And the angle, as the word says, costo means ribs and vertebrae. So that's where the angle is, right there where the ribs meet the vertebrae. That's the angle they're talking about. It's palpating it there, putting your hand down and taking your fist and palpating like that. And you should not have tenderness if you do not have kidney issues. So if they have issues, if they have tenderness, that may indicate they have got pyelonephritis. Treatments, antibiotics, and so forth. If I'm going through these pretty quickly, I'm not going to spend a long time on them because there's other things that are more important than that. Adult voiding dysfunction, by definition, is just emptying urine is a problem. Incontinence is not a normal part of aging. There's 3 different kinds. So like I said, I'm just not going to spend a long time on those because some of those are a little more. Teaching a patient how to do Kegels to strengthen your urinary muscle walls. We talked about that with uterine prolapse before. Pretend you're stopping your urine stream is how we teach patients to do that. We also have cone therapy, which we can strengthen your urinary muscles. That's like you holding up weights when you're working out in the gym. So we put a cone in place, hold it for so long at a time, twice a day, increase the length of time, increase the weight of the cones, and it just strengthens the muscles. There's lots of devices we can place into there. And there's other suspensions and things like that, which we already talked about. Like I said, if I'm not spending a long time on it right now, I'm not gonna spend time on it in the next couple weeks. Lots of meds, you know, if you have an extended release form, you gotta swallow it whole. Neurogenic bladder, we already talked about some of the neurogenic issues in neuro. So I'm not gonna spend time on that one either. But we will spend a little time on urolithiasis, which are kidney stones. And if you had a kidney stone in your past? Nobody? How was the pain? What'd you say? Worse than having a baby. Absolutely. You think that little bitty stone, how can that cause so much pain? Yeah, I had one in the past. I was driven from where I was at to the hospital by a friend, and I said, you gotta turn right on red. No, I'm not allowed to. That sign said I'm not allowed to. I said, today you're allowed to. I said, get with it. And then later, the lady at the registration desk was like, why are you here? I said, I'm always reading in the emergency room, and I see that bed empty. I'm just gonna go park myself right out. I'm like, wait! Not today. I'm not stopping today. Okay, what happens is the urine gets saturated, it builds up, and it forms a stone. The stones can be anywhere, usually severe pain, especially if you're making urine and you can't get it outflowed. Depends on where the stone is as to where the pain is, but usually the pain is severe, severe, severe. Because it's like you having urine in your bladder, and the next rest area, next place to stop on interstate is not for another 120 miles. You're like, oh my gosh, and then it just gets worse and worse and worse. So it can have, because of the pain, the patient can have vomiting, severe colic pain is what we call that when it's back there in your kidney area. You can have blood in the urine, that stone's irritating the urinary tract. When you have no production of urine, or very limited, that is a medical emergency. That term, when you have urine caught up in the system, that term is called hydronephrosis. So yes, you could expect to see that with your patient that comes in with a kidney stone, because that urine can't outflow. So hydro means water, nephrosis is in the kidneys. So hydronephrosis is a condition we call when you have urine that is retained and it can't outflow. Hydronephrosis is the name of that condition. Again, positive CVAT, which we just talked about, pyelonephritis. The stones, if we catch them, if we see them, we can evaluate what the stones are made of. So there may be dietary recommendations based on what your stone is made of. Maybe say you need to limit your calcium because your stone we found out was made of calcium. And sometimes we don't either catch the stones, the patient urinates, voids them, and we don't get to evaluate them. And sometimes there's really no correlation, but there may be dietary considerations. You don't need to know this, but it's just fun facts. Depending on the size, how likely is it you're going to be able to just pee them out on your own without intervention? I'm sorry. Pain relief, usually we'll go for either NSAIDs or opioids. The pain that's worse than having a child, get the opioids on board. So treatment plan number 1 is to get that pain controlled. Another treatment plan is what we call medical expulsion therapy, which is kind of a new term. It's a combined recipe of giving you a medication to relax your smooth muscles. That medication was the same one we talked about with BPH, if you remember. Pain meds, drink plenty of fluids, strain your urine when you go home. We want to see if we can catch your urine and analyze it. And then if we don't know if you passed it or not, do a follow-up imaging. But that's called medical expulsion therapy. And the hope's to relax your urinary muscles enough that that stone just flows on through. If that doesn't work, we may have to go something to a little bit more invasive. Lithotripsy. Lith means stone. Urolithiasis, lithotripsy. That's like jackhammering your kidneys from the outside. So you lay on the table and literally the shock waves externally are placed, in the hopes to break the stone down, in the hopes that you can pee it out on your own. Not invasive, but a little bit more aggressive than what we just talked about. Stents are always an option. If we can't get that stone to move through, we may have to open that vessel up, widen that to get your stone to flow through. We can always do a scope, putting a scope up in with the pincers, like we talked about with prostate surgery. Break your stone up, remove it as such through this tool or the device. Otomy means incision into. So we may need to put an incision actually into wherever the stone is and remove it with a tool again. So it all depends whether the stone is located there, we do this type of otomy, there, or if it's in the renal pelvis. Otomy means taking an incision into, putting a device in, and removing it through that device. If you ever look up natural remedies for kidney stones, you're going to find lots and lots and lots of thoughts about what to drink, what to eat, what to not eat. So I'm not going to hold you to any of these because we could just be here forever. So your patient has urine that's caught up, that's been produced, it cannot outflow. You can have permanent damage within 48 hours. If you have urine retained, that is not able to outflow out. So that's the situation with your patient. They decide to put an nephrostomy tube right into the kidney to drain it out through that tube. Your job as his nurse, keep him NPO, of course. The catheter is placed. Postoperatively, your job is to monitor for the things that are in red, especially. What does decreased drainage tell us? Correct, that the catheter is not draining the urine. What about the drainage that's cloudy or foul smelling? Infection. What about the side that leaks blood or urine? A bleeding complication, absolutely. And what if the patient has back pain, what is that telling us? Correct, bleeding inside, urine that's not getting drained, or a stone or something like that. So those 4 criteria, which makes pretty good sense, is what you want to monitor for, notify the surgeon about if the patient experiences any of them when you're taking care of this patient that has just got a nephrostomy tube that's got to put in place. And it isn't a caution sign, and it is in red, so that's important for you to know as the nurse. Dietary recommendations will depend upon what the stone is made of. So we'll have to see if it's a trend, if it's something that we can analyze, and maybe we need to suggest a change in your diet. There's lots of little synopsises that if you want to, pull them up, or especially when you get ready to take your NCLEX in May, just like some of these are probably helpful if you just want to have one little screenshot about, okay, let me tell me all the important things about this particular condition or this disorder. So tell me about your patient comes in, you suspect a kidney stone. What kind of problems is he going to have? Severe pain, renal colic is what we'll call that. What else? Okay, oliguria or anuria, not producing. What's the difference between those two anyways? Oliguria is less than 400. Anuria is less than 50, 24 hours. So no, hardly any urine output. Severe pain, what else? Hematuria, frequency perhaps. Nausea, vomiting, headache, stuff that goes with severe pain, right? And what's the condition called if he's retaining urine? Hydronephrosis, you may see that, right? So he comes in, what's your treatment plan? We're going to go from least invasive to more invasive. What's one of your priorities? Pain control. And what could be maybe, I don't know if I went over this, but sometimes if it's, the first step from is starting an IV. I'm going to run a bunch of fluids through there in hopes to get your stone run all the way through and irrigated out of there, right? So you got a pain control, you tried an IV, that didn't work. What's another piece? And what kind of medication do we use for that? Flomax, right? So we're hopefully maybe relaxing your urinary muscles, to get that stone to flow on through. Flow on through. Okay, what's the next, another treatment? And what is that called? Lithotripsy, what is that even? Right, that came from the outside, it's called ESWL. Okay, so what's another treatment option? Scoping, what do we do for that? Okay, break it up, grab it, there you go. We can always put in a stent, right, to open up the vessels. We can always put in one of the otomies. What do we do for that? Cut them open and put the tool in and take it out, correct, where that is placed. And if we have urine that's retained in there, it's not outflowing, and he's got hydronephrosis big time, nephrostomy tube, and your job as a nurse is to monitor when that nephrostomy tube is in place. The drainage, color, consistency, odor, amounts, all that kind of stuff. Questions about kidney stones? There may be dietary considerations. If we evaluate the stone, we may have dietary recommendations for you.
So yesterday, my patient at Renal had a kidney stone.
Had what? Okay.
They sent her down for a procedure, but I thought she mentioned something about the laser. They use lasers to bust them up better, or is that just something else?
Yep, I guess that's probably an option too. We can laser bust
I didn't
anything
know.
up, right? Yep. Yep, I guess that's a possibility. It's probably some version, kind of like the lithotripsy.
They use to bust up that. Dr. Khan does it in. So it wasn't laser.
Okay.
I was confused.
Okay. So, all right. Bladder cancer, number one risk factor is tobacco use. Again, we talked about that earlier. Chemical exposure, including tobacco use. This is an important slide to know. This is an important slide to know. Sometimes we'll instill a live virus into the bladder, allow it some dwell time. Because you know it's a live virus, you're going to send that patient home, and you're going to tell that patient, you know what, for the next time period, at least 6 hours, you need to contain your urine. Because your urine still has some live virus in it. And we don't want you sharing that with your family members, right? So a separate toilet, men sit down when you're urinating, we don't want anything splashing anywhere. Clean the bowl afterwards with some bleach, wash your clothes separately. No sexual contact for a few days. So the whole principle of what can I have to do to educate my patients so that live virus doesn't get accidentally given to someone else in this household is where your brain needs to go with that. So about 6 hours afterwards, this is a safety issue. You do need to know that. Thinking, okay, I got a live virus, I gotta make sure the patient doesn't go home and potentially give that live virus to someone else that's living with them. Questions about those patient instructions? So basically, just contain your urine for 6 hours and all the things that go with that. If you only have one toilet, perhaps everybody in your household needs to go somewhere else for the next few hours until we're past that time frame. Okay, urinary diversion devices. You will need to differentiate those. It doesn't matter, it matters, but it doesn't. Some of them are connected in different ways. You don't have to know that to that specific. But what you do need to know is, does it mean that I have to catheterize through a stoma to get the urine out? Or will I wear a stoma bag that will drain the urine? Because you're going to need to do the education for your patient on this one. And with any luck, I'll get this YouTube clip for that. And it's got a really good synopsis of a lady that has an ileal conduit. Any luck, we'll have her tell you about that. No falling asleep if I turn the lights down. I know it's tempting.
When
I talk to people who are at a position where I was prior to surgery. I tell them that it's not going to be nearly as difficult as they think. We all tend to think that the worst is going to happen, that we're going to be in incredible pain.
Alright, anybody have an idea on that? Still don't have her. Alright, anybody, yeah, who's the IT person here?
Oh, why are you looking at me?
Cause you're the expert on it.
I thought you would volunteer